I'm Karen Scott, President of the Foundation for Opioid Response Efforts, and I'm so pleased to welcome you to today's webinar. This is the third in a series we're doing, which we at FORE are highlighting the work being conducted in each of our major programs. Today's program focuses on our Innovation Challenge program. You will hear updates today from 4 exciting grantees and their work: the Agency for Substance Abuse Prevention, the University of Massachusetts Dartmouth College of Nursing and Health Sciences, Brown University School of Public Health, and Tufts University. For those of you new to us, I will do just a brief introduction to FORE and this program before we get into our presentations. Following my introduction, you will hear from the following 4 programs: our faith-based specialist support specialist program, the novel organizational simulation training to improve graduate mastery and attitudes, or no stigma, at the College of Nursing, understanding drug use within a rapidly changing supply, lessons learned from Rhode Island, and the syndromic surveillance to prevent overdose in Lowell, Massachusetts, data to action and evaluation. So 2 projects very much focused on novel and innovative ways of training different professionals in the field, and 2 focused on improving data, timely and actionable data. That will all be followed by a Q&A session led by FORE Program Director, Dr. Ken Schatzkes. We encourage you throughout the presentations to please submit questions and be part of that discussion. Just briefly, overall, in terms of logistics, the webinar is being recorded and will be available on our website shortly after the session ends. The slides from today will also be made available for download on our website. Please use the Q&A button found at the bottom of your Zoom screen to ask questions. It also gives you the ability to upvote questions that someone else has submitted so that those will go to the top of our list. And we will try to get through as many questions as we can and engage as many of you in the discussion as time permits. Finally, and very importantly for us, there is a brief survey immediately following the webinar. Please provide us with your feedback. We like bringing new information to you as our grantees' work continues to develop. We'd love to hear your ideas as well as feedback on how we can continue to do that. Thanks. So, the foundation was launched in 2018 as a national private foundation to support solutions to the opioid crisis. And to date, we have awarded 70 grants, committing close to $32 million to this mission. In fact, our most recent grants were just announced yesterday, both grants to California Bridge Program on Emergency Department access to treatment, as well as to the RAND Corporation to study access to treatment through mental health clinics. All of the work is focused on aspects of advancing solutions to the opioid crisis. And I encourage you to visit our website to learn more about the details of the grants that we're supporting. Thanks, Ken. Overall, our 4 major program areas to date have been a focus on access to treatment for vulnerable populations. Second program focused on responding to issues we heard about early in the COVID-19 pandemic, and through that we supported a number of recovery services to help stay connected to people during the pandemic, as well as the evaluation to learn better what the impact of temporary changes in regulatory policies had been during the pandemic, and how we could learn from those to really improve and inform longer-term policy. For example, the use of telehealth to improve access to treatment. The third program, which we launched just early this year, is our Innovation Challenge, and you will hear more about that program today. And the fourth one, also launched early this year, is our family and community-based prevention program, very much focused on children and families at high risk, and a focus on more upstream interventions, including building resiliency and strength in families and addressing adverse childhood experiences. But today is a focus on the Innovation Challenge. We launched a national request for proposals in mid-2021 to generate ideas and work focused on what always seemed to be some of the major barriers to really making significant improvement and advancement around solutions to the opioid crisis. And two of those barriers often come back to aspects of stigma towards patients with opioid use disorder, as well as having better, timely, and actionable data. We asked in the RFP for novel ideas, for ideas and projects that would fill ongoing gaps related to stigma and data. And particularly important to me was we asked for ideas and projects that would really bring together different disciplines, different sectors, recognizing that cross-sector, cross-discipline collaboration can often be the place where innovation happens. I'm thrilled to have this slide up and to show the awards for 2-year grants that we've made to these 11 organizations to form the basis for this program. Frankly, with some of these, we took a little bit more risk than we have with some of our other grants, but clearly with that risk, we are seeing really great rewards. And you're going to hear from those, from 4 of those projects in a moment. And we can go to the next slide. And the presenters today for those 4 projects are here. We will start with Reverend Byron Jackson, the Faith-Based Support Specialist Program Ambassador at the Agency for Substance Abuse Prevention in Alabama, Dr. Marinda Teo, Assistant Professor at the University of Massachusetts, Dartmouth College of Nursing and Health Sciences, Dr. Alexandra Collins, Assistant Professor at Brown University School of Public Health, and Dr. Shikhar Shrestha, Assistant Professor at Tufts University. I'm very pleased now to turn the program over to Reverend Jackson. Thank you all for joining us.
All right, good afternoon. Thank you, Ms. Scott, for that introduction. And of course, as already stated, I'm Reverend Byron Jackson with the Agency for Substance Abuse Prevention. Also here with my Executive Director, Mr. Seyram Selassie. We are of course, and primarily grateful to FORE for the funding for this program to allow us to do this work throughout the state of Alabama. And so the Agency for Substance Abuse Prevention is a prevention agency based in Oxford, Alabama. We are about halfway between Birmingham, Alabama, and Atlanta, Georgia, right on the I-20 corridor. And we're glad to be before you today to share some lessons that we've learned about as we've gone through this program. So if we can go to the next slide. This is just a quick picture of the team there at ASAP, the Agency for Substance Abuse Prevention, which I'll hear from this point reference as ASAP. But we are a team of about 11 now. We're a growing agency that does prevention only. So we focus on education. We don't do any treatment in our agency. We're only a prevention agency. Next slide, please. So the Faith-Based Support Specialist Program is a brainchild of ASAP after noticing a gap between the mental health field and the faith-based community. We recognize that most people turn to their churches in times of crisis, as you'll see shortly, but I did want to start by letting it be known that this is an ecumenical program. It is focused on all religions and all faiths, and even all denominations of the Christian faith. It's important that we understand that we wanted to reach all of these faith communities in order that we can reach and help as many people as possible and deal with the stigma as widely as possible. Next slide, please. So when I present this to various ministers or before denominations statewide, I always start with the simple question that I've tailored for this presentation. Most ministries, are they equipped to handle substance misuse issues? The truth is, people do turn to faith in times of crisis, right? And so what we created out of this was a program that would allow the church to be a place where people can indeed turn, but not just turn there because of what it is or who the church is, but when they do turn to it, they can find the help that they need. Mostly what we encounter is that within the church, and I myself am a pastor in Alabama, we must ask the question about what do we do with people in the faith-based community as it pertains to substance misuse. So when they do come to us, what is it that we do for them? We actually found through research that most people who have gone through treatment and are now in recovery have actually stated that they turn to their church in getting help with overcoming their substance misuse, and found that pastors like myself oftentimes were not equipped to be able to give them the practical help that they needed in order to overcome these diseases and disorders. Next slide, please. So therefore, we get into the purpose of the program. The Agency for Substance Abuse Prevention, through this program, wants to press forward into the faith community that prayer, prevention, and treatment do indeed work together. Because of the stigma, which I'll reference in just a moment, because of the stigma in the faith community concerning mental health, a lot of times people fail to understand that faith and science can work together. They can walk together. And so the same is true for prayer, prevention, and treatment. And so we want to eradicate this stigma within the church in order that we can start with pastors, these senior level religious leaders, and allow there to be sort of a trickle down effect within the ranks of the church, in order that our parishioners, as well as people within the community, can find the help that they need in overcoming substance use disorder. Okay, I already referenced the gap between the faith-based community and the mental health field, but our primary goal with this program is to remove the stigma surrounding mental health. Like I say, I'm in the Deep South, in the Bible Belt, pastoring a church here in Alabama. And I went to seminary and I'm trained, but the truth of the matter is that for most of us, especially in this area, there's a belief that we can just pray everything away. That if we prophesy and we declare it, that it'll just disappear. While I am a man of faith, I also believe that God is able to work through people, right? And so through science, through professional advancements, technological advancements, and through scientific advancements, we can be helped in specialized areas, this being one of them. So we, through this program at ASAP, seek to connect the church to certified resources. And that is what makes and has set this program apart from all of the other programs that may be of its kind. We pitched this to the Alabama Department of Mental Health, and they have backed the program. We're grateful to FORE for the funding, but our own mental health department here in the state of Alabama has backed this program wholeheartedly. Next slide, please. So as I already stated, I just wanted to trickle in some pictures here so you can see kind of what takes place. And you'll see more pictures of this training in just a moment. But I did want to point out that these are certified trainers and facilitators who are imparting knowledge into these program participants. That is actually Ms. Denise Morris, who works and is moving up the ranks of the Alabama Department of Mental Health as we speak. And so next slide, please. Now, so let's look at the program specifically. This is a 16-hour conference over 2 8-hour days. So all participants who are recruited and who sign up for this program, they come to whatever location we're having it at, and we are doing this quarterly statewide. So we started in Oxford, Alabama, which is our home. And then we went to Huntsville, came back down to our state capital in Montgomery. And then we're now, as a matter of fact, right now, we're here in Mobile at the Region 4 conference. So we are taking these senior level religious leaders for 2 days, 16 hours, 8 hours each day. And at the end of those 2 days, they are indeed a faith-based support specialist. Now, I do want to clarify that we are not training and certifying them to do the assessment or to carry out the treatment or to even start a treatment center. What we're wanting to do through this education as a prevention agency is educate them and inspire them to work in this field in order that we can eradicate the stigma, but also so that they can enhance their ministerial tool belt. That's what we call it here at ASAP, the ministerial tool belt. We want to add tools to it and enhance it in order that they might be able to more effectively minister to those with substance use disorder now that they have been given the tools, skills, and resources to better do so. Okay, at the end of those 16 hours, all participants are in fact an FBSS or a faith-based support specialist that's backed by ADMH. Okay, next slide, please. Now, what you see here is our last training that was held September 22nd and 23rd in Montgomery, Alabama. This was actually held, as you can see, the beautiful venue that we were in on the campus of the University of Troy in Montgomery. And on that campus, we were actually blessed to have it in the brand new Rosa Parks Library and Museum. And this actually gets to two of the big things that we've learned throughout this process. Number one is that within the faith-based community, we've noticed that there are silos. That a lot of pastors and leaders operate in silos. They don't work together. As a matter of fact, we could be on the same street, but because we're not in the same circle, didn't go to the same school or are part of the same denomination, we don't work together. And what that does is it weakens our ability as a community, as a holistic community, to be able to speak to these issues and have a united front and effort as it pertains to how we as a faith community will speak to these particular issues. That's the first thing. And as a part of that, bringing these leaders together, we actually saw that this is the first time really since the civil rights movement that we've seen pastors of different faiths, pastors and leaders, clergy of different faiths, but also pastors of different races coming together to tackle one particular issue in a united and concerted effort. But the second thing we also saw is this stigma, right? But as we know that we're fighting against the stigma, but what we've learned, secondly, is that most pastors, until they came to this program, didn't even realize that they were biased in this particular area. They didn't know that they were ignorant. They didn't know that they had a very tight lens as it pertained to this and didn't have a good worldview. And so putting them in the room with treatment facilities and facilitators, putting them in the room with ADMH representatives and hearing these sessions and getting this education has allowed them to recognize that there is a stigma and we do need to fight it. Next slide, please. So these are some of the topics. I won't insult you by reading them all, but these are some of the topics that we cover in every one of our actual training conferences. Like I said, we're in the midst of one right now. And so you can read those. And of course, you'll be able to see those even after this is over and they send the link out. But next slide, please. This is actually the inaugural training, the very first one that we had right at home, about a mile away from our agency in Oxford, Alabama. And if you see in those photos, these pastors are fellowshipping, sharing together in that center picture, but also in the picture on the right, you see that there's a Catholic priest and he's sitting at the table. It's a little cut off with a Baptist pastor. And we're all actually these two are in the same city that I pastor in, but we had never met each other prior to this actual training conference. So it's bringing people together, building bridges and relationships, and killing multiple birds with one stone by bringing them together in this program. Next slide, please. And so we talk about, as we prepare to get to the end of this, the role of a faith-based support specialist, it is an official certification. So they do have to maintain their certification and earn 8 hours of continuing education over the course of 2 years. And at 2 years, they will be up for recertification. But we also want them to become the mouthpiece and the marketers for this program by telling other religious leaders about it, because religious leaders are people-based, right? And so they work in circles. And so we want them to share with their colleagues and their communities those things that they are learning, and how these people can come and learn more about it and receive a certification on their own as well. Then we also, of course, want them to work in their ministries to remove the stigma by starting programs, right? By changing the way we speak about these topics from our pulpits and from our podiums, right? How is it that we, now that we've been educated, can help eradicate this stigma? And then one of the biggest beauties of this program that we found, and one of the parts that the participants love the most, is the fact that after they leave this training, they have certified resources in their particular area at their disposal. We just, in the conference that we're doing right now, the prevention agency of Mobile County stood up, and while one of my colleagues was presenting, gave her cell phone number to a room full of pastors and told them, hey, if you need anything, don't hesitate to call. We do counseling in our office, and we can also refer to treatment. So the pastors don't have to carry that load on their own, but now they're connected to these treatment facilities in their own communities. And then, of course, in order to show people like FORE the validity of this program, we need to report the strategic prevention framework data in order that we can show the progress and validity of the program. Next slide. And then the impact. Lastly, we started this program this year, and the impact of this program has been amazing, not just in the number of people as of today, and this does not count the one we're doing now. We've certified 88 clergymen and women of various denominations and faiths, and we've certified them, right? But another sort of backside impact, I guess you could say, to this would be that we're seeing the LGBT community, because in our one in Huntsville especially, it's amazing to see a priest that is a part of the LGBT community that is working with a Southern Baptist pastor, and they're sitting at a table working together on how it is that we can eradicate the stigma in some of the activities that they have to do throughout the program. Lastly, very quickly, this program has built such steam that we were recommended by ADMH to connect with SAMHSA, which is the Substance Abuse and Mental Health Services Administration. We've connected with them. We are preparing for at the end of next year, December 7th and 8th of 2023, we're going to carry out a SAMHSA Region 4 conference that covers 8 states: North Carolina, South Carolina, Georgia, Tennessee, Kentucky, Alabama, Mississippi, and Florida. And we're going to bring all of these states and join them in the fight against this. And we've already been talking with FORE about how to expand this program as well. And so we're grateful and thankful for their support. But we've learned about the silos, we've learned about the stigma, and we've also learned about this separation, but bringing these pastors together, whether it's race, creed, gender, sexual orientation. We've learned quite a few things so far that are helping us to continue to make this program better. And so we want clergy to continue to recommend this program as we seek to continue to carry it throughout the state of Alabama again next year and expand it to a SAMHSA Region 4 program. Thank you. Yes. And so at this time, we will pass it over to Ms. Miranda Tayo, who's an assistant professor at the University of Massachusetts, Dartmouth, in the College of Nursing and Health Sciences. Thank you.
Thank you, Reverend Jackson, for that introduction. And thank you for the opportunity to speak today. Our project goal, the novel organizational training to improve graduates' mastery and attitudes, the No Stigma Simulation Suite. Our goal was to develop 6 high-fidelity simulations to address stigma towards individuals with opioid use disorder. Next slide, please. The simulations were created from focus groups with our community partner, the Massachusetts Organization for Addiction Recovery. And the focus group participants included persons coping with opioid use disorder, family members, and group support leaders such as recovery coaches, certified peer support specialists, counselors, and social workers. The aim of the focus group interviews was to identify stigma, barriers, and facilitators experienced by members of the OUD community when interacting within the healthcare system. 8 themes emerged from these focus groups, and they're listed on the slide, including stigmatizing language used by nurses and other healthcare personnel, being labeled as a barrier to care, inequitable care secondary to OUD stigma, recognizing opioid use disorder as a chronic illness can actually facilitate care, entrance barriers, stigma associated with medication for opioid use disorder, community resources, and nurses lacking knowledge and how that impacted care. Next slide, please. So our 6 simulations, the first one, access to timely care, takes place in an emergency department setting. A young male presents to the emergency with a wound. He has social determinants of health, such as no insurance, and he's devalued by the staff caring for him, and he faces significant delays in care and stigmatizing behavior. So the goal was to establish a trusting rapport with the patient using communication and empathy. And this simulation can be used really to target undergraduate nursing education. It is an unfolding case study, and it unfolds to the next scenario, pain management. In this simulation scenario, it takes place in an acute care setting. So the same patient is admitted to an inpatient ward, and he has acute withdrawal symptoms and significant pain. The goals of this scenario are to identify and treat withdrawal symptoms and provide effective pain medication. The student should gain an insight on the neurobiological factors of opioid use disorder and how family dynamics can impact outcomes. The students practice making a referral to support services, and this scenario can include both undergraduate and graduate students. So the learner can be a Bachelor of Science nursing student or a doctoral nursing practitioner, and they can also work together to provide care. And the next scenario, family-centered compassionate care. This simulation setting takes place in a level 2 nursery, and the scenario includes an infant with neonatal abstinence syndrome, and it's designed for master students preparing to become nurse educators. And the master students must address stigmatizing behaviors that they may encounter in practice and redirect those healthcare providers to promote family-centered care using an empathetic approach. Next slide, please. Our 4th scenario is harm reduction, and this also takes place in the emergency department. In this scenario, it focuses on promoting a trauma-informed approach using motivational interviewing. It's designed to help students recognize higher risk populations, and it also includes harm reduction for patients that may not be ready for treatment. The scenario can be used for all levels of students or students working collaboratively to care for the patient together. The next scenario that we have is medication for opioid use disorder. It's a rural care setting. In this scenario, it takes place in a primary care clinic using telehealth. A young fisherman is seeking treatment for medication for opioid use disorder, and the nurse practitioner students must navigate the stigma associated with medication for opioid use disorder, treatment misconceptions, family dynamics that are related to medication for opioid use disorder, and they must initiate expert screening and interprofessional collaboration. And then our final simulation takes place in primary care, and it has an older adult female who's concerned about having an opioid use disorder label in her medical record and how that may impact her future care. The nurse practitioner student must use the SBART screening, prescribe evidence-based treatment, and demonstrate a warm interprofessional handoff. Next slide, please. So community and expert collaboration is very important. The content for each simulation was validated using focus group interviews with a panel of substance use disorder experts that included healthcare providers who were also nurses, who are also nurse educators or family members affected by opioid use disorder, and their experience ranged somewhere between 5 and 39 years. The following themes emerged from these focus group interviews, including strategies for enhancing realism, recognition for diverse patients, additional cueing to generate empathetic responses, refining cueing to focus on stigma, not just medical treatment. Opioid use disorder is a chronic illness. We did obtain consensus between experts. And then there were some limitations mentioned about the simulation mannequins. For instance, it's very difficult to simulate pain on a simulation mannequin, even though it's high fidelity. The facial reactions may not be present to cue students. And then most experts found that it was a novel approach to standardize patients. Next slide, please. This project did present an opportunity to engage undergraduate and graduate students in opioid-related research and to include opioid stigma education in nursing curriculum. The No Stigma Simulation Suite has several innovative approaches, including the ability to span the entire undergraduate and graduate nursing curriculum, the use of telehealth as a simulation setting, a diverse patient set, including mixed ethnicities, LGBTQ+ populations, and older adult populations. It also includes suggestions for how to enhance simulations using interrelated concepts of pain management, recognizing early withdrawal symptoms, social determinants of health, LGBTQ+ health, and sex trafficking. Next slide, please. Our challenges included recruitment of diverse community members and scheduling conflicts. Strategies that we would recommend for future research and collaboration include collaboration is essential. We focused on treatment and recovery community partners, but expanding to other community partners may offer a more heterogeneous sample. So maybe thinking about people who are not yet engaged in treatment or recovery. We offered video conferencing for focus groups, and in the future, offering a variety of modalities could help eliminate any economic inequalities for vulnerable populations. Also, considering the needs of the community partners is very important when you're choosing incentives. So we offered an Amazon gift card, but in the future, a nominal cash exchange or a local grocery store gift card could be used without providing the person's name or mailing address. And this can navigate some economic and societal challenges. Respect and acknowledgement for historical mistreatment. And then finally, adding more diverse members to our research team has been and could be beneficial. To optimize student participation, we did offer flexible scheduling. So we offered sessions on weekends, evenings, after final exams, in between semesters, and this has been helpful. Next slide, please. So for our recommendations, the No Stigma Simulation Suite has the potential to influence nursing curriculum and nursing practice by providing the next generation of nurses with knowledge, skills, and attitudes that are needed to advance health equity for individuals with opioid use disorder and their families. The simulation suite can help learners to recognize the benefit of a multidisciplinary approach to comprehensive treatment. They can recognize the nurse's role in effective communication, recognizing withdrawal, managing pain, and facilitating coping, and to help recognize and respect that different approaches are needed for opioid use treatment. It's not a one-size-fits-all. And then also how to provide multiple opportunities to initiate harm reduction strategies. Next slide, please. These are our data generated. So our research team has published our first article, Stigma, Barriers, and Facilitators Experienced by Members of the Opioid Use Disorder Community when Seeking Healthcare. This was published in the Journal of Nursing Scholarship, and it's an open access article, so it is available. Thank you to FORE for the funding to provide an opportunity to make it open access. And then findings from that article were presented at a regional conference, the Council for the Advancement of Nursing Science in Washington, D.C. And then we have some forthcoming presentations We've been accepted for a podium presentation at the International Family Nursing Association Conference in Dublin, Ireland, and that will present development of family-centered simulation to address stigma with neonatal absence syndrome. Next slide, please. And these are some additional presentations that have been submitted for regional and international conferences that are upcoming. Thank you. Next slide. And now I'd like to introduce Dr. Alex Collins, Assistant Professor at Brown University School of Public Health, who is going to speak on understanding drug use within a rapidly changing supply, lessons learned from Rhode Island.
Thank you so much. And thank you both for the invitation and also the funding to support this project. Next slide. And so I may be preaching to the choir here, but we are in the midst of an ongoing overdose crisis, and this has very much taken different waves. And so kind of the most recent wave being this rise of illicitly manufactured fentanyl that's entered the drug supply. But we're now in this fourth wave, which we're seeing a lot more kind of complexity in the drug supply. We're seeing overdoses that are contributed to polysubstance use. And this has really made understanding, one, what's happening, and two, how we can support folks much more complicated. It's a much more different approaches are really needed to support people in this current context than it was when folks were using, say, only heroin. So we're in this really complicated situation, and we're starting to see a lot more novel psychoactive substances entering drug supplies and really impacting overdose experiences and drug use practices. Next slide, please. And so kind of we think about how are we tracking and how are we understanding the drug supply. Right now, a lot of drug surveillance really is using kind of drug seizure data or leftover overdose biospecimen samples, relying on postmortem toxicology data. And while this is helping us understand at some level what is kind of moving in and out of the drug supply, there's a lot of delays in how these are both tested and reported. It also really doesn't help us understand how people are using. If we're using seized substances, or if we're relying on post-mortem data, we aren't able to really chat with folks and understand what are their experiences, what were their drug use practices, and really understand how people are using certain substances together and the impact of that and how we can better respond. Next slide. And so that brings us to TestRI, which is a toxicological and ethnographic drug surveillance study based in Rhode Island. And next slide. And we have this really amazing team of people. Sorry, the next slide. That is from a really diverse background. So I run this project with Dr. Rachel Whiteman, who's a medical toxicologist and ED physician. We have really incredible toxicology folks, science communication people, our data manager, and he helps produce all of our data visuals, and our research assistant who makes all of this work possible. So we really come at this issue from a really diverse background, and this has allowed us to take a lot of innovative approaches to collecting data and presenting data in a way that we really are able to kind of rapidly communicate what we're seeing in the drug supply back to folks. Next slide. And we also do this work in collaboration with really amazing community partners. So this includes some of the largest harm reduction agencies in our state, as well as opioid treatment providers. And we also are in very close collaboration and do this work with the state's Department of Health. Next slide. So to talk a little bit more about TestRI, we are a two-year project. It's a community-based research project, really that was born out of discussions with the community. We've talked with addiction physicians, we've talked with people who use drugs, folks in the community, frontline service providers, and really it kept coming to people don't know what we don't know what's happening. People don't know what they're using. And people want to know what is in the supply and how we can really help folks reduce the risk of fatal overdose. So taking that as kind of our base, this project uses both qualitative and ethnographic research as well as toxicology testing to really try to understand what's happening at this individual level in the drug supply. How is it impacting people's consumption practices? And then also, how is it changing kind of on a month-to-month basis or week-to-week basis across the state? And then we want to take that knowledge and that info and rapidly give it back to people who use drugs, as well as service providers and more broadly across the state, so we can inform local overdose prevention efforts. Next slide. So we really kind of have the focal point of this project is sample collection and testing. So we do collect a range of samples. So this can be syringes, pipes, cookers, refuse, or actual products that people donate to us. And that we get these samples from kind of two different pathways. So one is either we have a participant who's enrolled in our cohort, we interview them, they have the option to donate a sample for testing. With that sample, they receive individual tox results back of what was in the sample they gave to us, and they also get the broader group that we've tested within kind of that last month. And then we try to get their feedback. What's useful? You know, what did you find surprising? What are you going to do with this info? You know, how might it change? And then we'll circle back to them in 6 months for a second interview. Or people can donate samples to us anonymously. This usually is through outreach workers. They know the folks have heard about the study or heard that there's something happening and they can get some drugs tested. And so they'll donate a sample to an outreach worker who will give it to us. And then we are able to give back kind of group-based tox results. So if we have had a few samples from one community partner organization, we do a specific kind of update on what we found in samples collected at VICTA. That way, if someone did donate there, they can see out of what we tested, maybe one of those was theirs. Just since it's anonymous, we don't have their contact information. And then we also are doing some feedback surveys for people who are not in the cohort to try to understand what we can do better with how we're communicating this data so it's the most effective across populations. Next slide. So when we collect the samples, it's really helpful when we're able to talk to the folks. So that is, most of our samples are provided by participants. And we're able to document the location where they purchased the sample and also what they think they purchased. So we have that label and we're able to use it to compare to what we actually find. So all samples are then dropped off at Rhode Island Hospital Laboratory, which is operated by Dr. Badea. And she runs the confirmatory testing on an LC-QTOF mass spec. So this is a very comprehensive, very intense mass spectrometer that is one of the most comprehensive forms of drug testing that we have access to. So this is, she's able to kind of compare what she's seeing in the test with this very extensive library of substances. And her and our co-PI, Rachel Whiteman, are able to kind of analyze and understand what we're seeing in each sample, what substances are there, and then the clinical implications of that. Next slide. So we are at kind of December 2022. We've collected 90 samples, or tested 90 samples to date. Our goal is to reach 100 before the end of the year. We've done all of our baseline interviews with 50 people who use drugs. And we're slowly kind of getting more of these feedback surveys, which will follow up in the new year. Next slide, please. So some preliminary findings. So of the tox samples we've tested to date, so out of 90, we really have worked hard to kind of collect samples across the state. Just over half of the samples have been out of Providence, which is our capital, but it is also the largest kind of area of substance use in the state. So it is it's quite proportional to what we're seeing in terms of overdose hotspots. But we've really kind of covered more of the Rhode Island rural locations, as well as kind of the metro kind of urban core. So that's Providence, Pawtucket, and Central Falls. In terms of what we've collected, most of the samples were purchased as fentanyl, with the second most common substance purchased was crack, but we really have gotten quite a range of samples from MDMA and ketamine and Xanax to Percocets and crystal meth. So we really are trying to, in this latter phase of the project, focus more on some of these sections that we haven't had quite as many donations to. So, but we kind of overall are able to paint a decent picture of the local drug supply in Rhode Island at this time. Next slide. And so out of the 90 samples, kind of the biggest finding that we've had is that 45% contain xylazine. And xylazine is a veterinary sedative. We've started seeing it crop up more and more in the drug supply. It's been around in Philadelphia for quite some time, but we haven't seen it as often in kind of Rhode Island. So to have out of 90 samples, 45% containing xylazine, it was quite surprising to us. This is not a substance that has been used in humans. So we don't fully understand the extent to which it can negatively impact folks. Right now, we know that it is a sedative. It is creating a lot of kind of sedation and ongoing grogginess after people use. And it also is contributing to some pretty intense soft tissue and skin wounds. And in our samples, every time we have found xylazine, it has also been found alongside fentanyl or a fentanyl analog. Among our stimulant samples, of which we've had 28, 39% of them did contain fentanyl or a fentanyl analog or tramadol. And this is really important because we haven't messaged in the best way at the state level that the overdose crisis really impacts everybody. We've really kind of kept it this language around opioid crisis. And for folks who predominantly use stimulants, that's had a significant impact. People don't always feel like they are at risk of an overdose, but what we're seeing in the supply is that even in the stimulant samples, we are seeing opioids, and we really need to work on messaging that to ensure that people have access to the right resources. And out of the pill samples, I do want to highlight it's only 7, but out of all 7, 86 did contain both fentanyl and xylazine, and one of the samples contained a designer benzo. And so we are seeing kind of the implications of some of these new substances that are kind of cropping up. And it's helping us be able to communicate this to frontline service providers and find better messaging so we can create the right resources to support people. And all of our samples we've tested to date, we update in real time, and you can follow it testri.org, which is hosted on the state's overdose surveillance dashboard. Next slide. And so in terms of the qualitative findings, this is the other kind of key piece of this project is understanding people's experiences, both at baseline, and then we'll chat with people in 6 months as well to see how they've interacted with the messaging that we provided, how their drug use may or may not have changed, and kind of what else they're experiencing in terms of gaps. So there's kind of 3 main themes I wanted to highlight. The first is that folks are really learning about the drug supply from a range of methods. So from their peers, from their sellers, and a few also were really kind of leveraging the internet to understand what they were maybe buying. And so for a lot of people, sellers were described as helping them gauge the strength of their product and how much to use at a time. Most people did know that what they were buying is probably fentanyl and some other things, but they weren't aware of just how complex the supply has been. So a lot of people really did kind of leverage and lean on sellers to understand, like, okay, this batch I have is a bit stronger, maybe reduce how much you're using. And then when we're giving people this supply info back of the substances they purchased specifically, people have found it incredibly helpful. They really have liked having this information and felt like it was useful to take back to their communities, back to their friends, and also to their sellers to say, like, look at what I got from you. Look at what's in the supply. Like, how can we manage this? What else can we do? So people really are kind of creating this communication pipeline back to share what they're seeing with their communities. But again, people did know that the supply was complex, and they really kind of framed using this day and age as like playing Russian roulette. So people, really were aware of how much stuff had changed. And a lot of the folks in our study have been using for decades, and they were just describing the differences between when they started using to today and just how complicated it has been. So people really are working to modify their use based on the quality of substances and how much they can get out of it. So there has been people shifting their use from injection to smoking. So working on different harm reduction practices based on kind of what the supply is like right now. And people really are most often engaging in some test shots or test bumps if people kind of smoke or snort to judge the strength before they use. And then kind of the last piece, which is really important, is that people are describing that with the products that they're purchasing now, you know, I will say the caveat that most of our sample, their preferred substance is fentanyl. They're able to feel high, but it's not always addressing their withdrawal symptoms. So people know that something else is happening, something else is in the supply that's complicating their ability to manage their withdrawal symptoms. And for folks who use stimulants, you know, many of them weren't always aware, didn't always really trust that the stimulants were as contaminated as, say, fentanyl supply. But for some who maybe were kind of not decades long in use of stimulants, they did kind of feel like fentanyl was unavoidable, or that it had been intentionally added to keep people coming back and coming back. And then lastly, this kind of change in the local supply had created some additional challenges for participants who were on medications for opioid use disorder. It made it harder, again, to kind of manage getting to the clinic or getting dosed when at the clinic, because people's, you know, urine tox screens may have come out with, including benzodiazepines, which can impact you getting dosed, but people weren't taking benzos. So because the supply is changing, it was just creating some specific challenges for these participants. Next slide. But the third aim of this project really is to take this info that we're finding and quickly get it back out to the community in a way to let people understand more comprehensively what we're seeing. Next slide. And we do this through a range of mediums. The first is through testri.org, which is our key kind of repository of data and all of our updates. So this page launched in June, and since then we've had over 2,000 visits, which is about 300 to 500 visits a month. And folks have spent just over 4 minutes on the page. So, you know, still a new page, but not too bad. People are engaging with this. And we know that a lot of kind of unique avenues, people have reached out to us that we weren't expecting, way different sectors have found us some way through this webpage and are really eager to learn more and how to get involved. So this really has been kind of a great way of sharing this much more broadly. Next slide. On this page, we have our local drug supply updates, which we developed. These are two-sided with a range of samples we tested in a particular month. It says the location we tested, what we tested, and what we found. It also includes harm reduction tips and on the back side, a glossary of info about each substance. So all of that is located here. People can download them. They're available in multiple languages. Next slide, please. And then we also have our kind of full data chart. So as soon as the sample is tested and confirmed, it gets uploaded. So it is in as near real time as possible. It usually, if we drop a sample off, we have confirmed results in about 2 to 3 days, and then we can upload it. So we are still working on kind of trimming how quickly we can turn things around, but this is at least a step in the right direction. Next slide. We also have a lot of other kind of dissemination approaches. We've done these, we call them spotlights of particularly problematic substances like xylazine. So it's a deep dive on that substance, some potential health effects, and then ways to reduce risk. We also develop these provider advisories. These go out to all licensed healthcare providers in the state of Rhode Island. And it's an update on what we're finding and what the implications are in the clinical setting and some approaches providers can take. And one of my favorite outputs thus far is our xylazine, which really was spearheaded by our research assistant who wanted a output really designed for people who are at drop-in centers, who are on the streets using substances. And this is a set of zines that she is taking the lead on. And it really is breaking down the information in ways with images of what to look for when you see wounds, how to kind of differentiate between a wound that's likely related to xylazine versus other kind of injection-related wounds, where to get care, and just some additional info. And she's also incorporated participant data from qualitative interviews in these, and folks have loved these. So it's a really kind of amazing iterative approach we've taken to making this info more accessible across audiences. Next slide. So some lessons learned. I think first and foremost, community partnerships are critical. This work happens solely because we have amazing community partners that trust in this project, that appreciate this project, and really believe in it. All of the kind of dissemination pieces we develop, we take to our community advisory board for feedback. They distribute it. We meet again. We try to understand what worked and didn't work for clients. We also use those feedback surveys. And, this really is a key piece to not only getting the work done, to getting the information back out there, but also just building up our capacity across the state for really supporting folks who use drugs. Similarly, working with state and or city departments of health can really help with scalability. We are much stronger when we work together. And, for us, Rhode Island's so small, we don't actually have city departments of health. We only have the state level, but the State Department of Health has been instrumental at helping us have this platform to really share our data. Kind of the third piece is that, for a lot of this work, staying nimble and being willing to iterate is really helpful. What we thought going in was going to be a great way of reaching people with information, it flopped a little bit, and that's totally fine, but we just keep trying to find better and better ways of communicating to folks. And so just being willing to do that has been, it's really important when we're doing this kind of work. Again, rapidly communicating findings in as near real time as possible. Often in academia, we write papers and sit on data for a long time, and, in a year and a half down the road, then it comes out. And for this type of work, it doesn't matter. A year from now, the drug supply is totally different. So it's really important to try to get info out and work with community partners to try to improve kind of programs and ways we're reaching people. One of the things that we found really helpful is giving people paper copies of their testing results. We've emailed, phoned, and texted people, but in all of those, they still ask us to have a paper copy. They want to be able to show that data. They want to show their friends kind of what they're seeing and distribute that. So it's been, a big kind of a lesson for us that technology is not always the best way. And then lastly, this work just shows how complex the supply is and how much further we need to go to supporting people. And this has to come from policy. We have to have substantial policy change, and we need to expand harm reduction service access, including access to overdose prevention centers and drug checking services to really, and having low threshold medications for opioid use disorder. All of these are necessary and need to be scaled up immediately to really kind of address some of the underlying contributors. Next slide. And thank you very much. So next is Dr. Shekhar Shrestha, who will be talking about syndromic surveillance to prevent overdose from Lowell, Mass.
Thank you, Alex. And before we begin, I would like to thank Ken, Karen, the folks at Foundation for Opioid Response Efforts for hosting this webinar and funding our study. And we are very excited to be here. My name is Shekhar Shrestha, and today I'll be presenting some of the preliminary findings from our study, Syndromic Surveillance to Prevent Overdose in Lowell, Massachusetts, Data to Action and Evaluation, and as we like to call it, Stop OD Lowell. And I also have our study MPIs, Dr. Tom Stopka and Dr. Jen Putz, without whom this work would not have been possible. Next slide, please. So in previous presentation, we went through kind of some summary of the opioid epidemic in the United States and the issues surrounding fentanyl and its analogs and drug contaminants and its impact on opioids. This is a small compilation of some of the news headlines that has become far too common these days. The increase in opioid overdose rates, the clusters of overdoses, overdose spikes, impacting a lot of people. And at the bottom, you can see some of the examples of alerts, warning spike in opioid-related overdose in the last 48 hours in Norfolk, public safety alerts, all of these, which are commonly, presented or produced by some public health departments which are in response to increased opioid overdose in the community. And with the current drug use environment, the possibility of increase in opioid overdose due to either increased use of fentanyl or a bad batch going around, or contamination of non-opioid illicit drugs with fentanyl and its analogs are pretty much common and could happen. And if you go to the next slides, we can talk about how organizations respond to these increases in opioid overdoses. So first, the efforts to reduce opioid-related incidents primarily rely on rapidly detecting clustered exposures and ORIs tied to fentanyl and other drug adulterants, and basically efficiently facilitating that information between public health, safety officials, and vulnerable community members who might be impacted by those contaminants or the bad batch going around. However, there are certain limitations to current systems. Current surveillance methods and subsequent alerts to community members are mostly reactive in nature. A lot of times, there is kind of a standard or cutoff that needs to be met in terms of 18 cases in X amount of hours, or 20 cases in X amount of hours for a local public health official group to come together and make a decision on whether or not to put out an official alert. And the next part is a lack of systematic information dissemination strategy. Like, where does it go out to? Who does it go out to? And more importantly, what people do with that information. All of that literature is not really available. And we really wanted to make sure that we focus on two main aspects. That is, making sure that we can detect opioid-related incidents as soon as possible. And second, that we come up with a really streamlined way of obtaining that information about spikes in opioid-related incidents and communicating those messages. Next slide. So this is where our main objectives come in. The objective one of our study is to improve syndromic surveillance in Lowell by reducing the response time to ORI spike detection by about 50%, to facilitate rapid dissemination of information and targeted response. And objective two was to evaluate the communication channels through which ORI spikes are transmitted and their overall reach. That is, who is it getting to? How long does it take for an ORI alert to be generated from the time that ORI was detected? And these findings will inform our work with stakeholders to optimize communication channels and by streamlining data to action flows and creating concrete response programs to make sure that we tie these alerts with something concrete in terms of action, and so that it really helps the vulnerable community members. Next slide. So before we begin to the actual preliminary findings of the study, I really want to point out some of our previous collaboration and research in Lowell. And the Lowell Peer Education Risk Reduction Study, this was spearheaded by one of our MPS, Tom Sopka, pretty early on, and which initiated the first brick and mortar SSP in Lowell and piloted peer education model to reduce injection-mediated risks, and constructed a lot of GIS maps and conducted spatial analyses to assess geographical risks for OD. Next slide. And more recently, we have made much more collaborative efforts and done some research in Lowell with organizations such as Life Connection Center, Trinity EMS, and Lowell Public Health Department, and UMass Lowell. And this is all to show that a lot of this work needs a lot of community collaborators and support, without which none of this would be possible. And over the years, we were able to forge these relationships, which helped us get started, get feedback, and support for the study so that we could act on this aspect of improving alert system in Lowell, Massachusetts. Next slide. So these are a couple of pictures from our recent visits to Lowell. We do a lot of work at LCC, and they have a couple of different new things going on. One of them was the mobile RV services. And in the last picture, we can see Tom, me, Jen, and one of our collaborators, John Kelly from Trinity EMS. And this is a place called The Owl, where a lot of folks who work in this field have been coming together and discussing life and a lot of work and the things that are going on in Lowell. Next slide. So coming back to the first research objective, that is to improve or reduce the time to detect ORI spikes. So we are using data from Trinity EMS services with a range from January 2011 to the most updated, our last update was July 2022. We use that data and identify opioid-related incidents in Lowell by using a combination of priority codes, complaint codes, nature of the ORI incident calls, and naloxone codes. Next, we geocode the incident location to identify where the incidents were happening and filtering the ORIs to Lowell, Massachusetts, as Trinity EMS serves also some other towns surrounding our study area. As for the data analysis, we do some regression modeling and predict cumulative incidence of ORIs in the 72-hour period, 48-hour period as a function of observations, trends in the recent days, and historical events and underlying socioeconomic and geographic features. Next slide. So this is kind of a raw, data showing the trends in of ORI incidents in Lowell, Massachusetts. We see kind of an increase in the periods between 2016 and 2019. After that, we have observed some dip in the ORI cases, but then again, I think late 2021, we saw some increases which have not been consistent, but we are seeing some uptick, and possibly which may be due to some of the changes that have happened because of the COVID pandemic. Next slide. In this graph, we show some of the variation that we observe with the ORI spike with respect to the day of the week and the time of the day. And for the most part, we see that the ORI calls happen mostly afternoon, mostly during 4 p.m. and 6 p.m. That's where we are observing a lot of the ORI incidents happening, and most of them also happening on the weekends, like Fridays, Saturdays, and Sundays, showing some form of temporal relationship in terms of time of the day and day of the week. Next slide. So in one of our modeling analysis, we predicted the cumulative number of ORI cases greater than 10 in the last 72 hours using cumulative cases in the last 48 hours, minimum area that includes the ORI cases that happened in the past 48 hours, and other space and time covariates. Basically, our hypothesis is that when we are working with a limited set of information, events that are closer in time and space are more likely to be related to each other. Therefore, ORI clusters, or cases that cluster in space and time, are predictive of an ORI spike. So next slide. So in the preliminary results, we saw that the number of ORI cases that were detected in the last 48 hours were very strongly predictive of ORI cases in the last 72 hours that would happen in the future. And this really helps. This really says that, okay, early decision-making could help reduce more ORIs, or ORI alert messaging can be put out a little bit earlier, but this isn't something new. We see a lot of cases in the last 48 hours. There's only a few cases that need to be observed to get to that benchmark. We did observe a large variation in the effect of time, both at a micro and macro scale. And our preliminary models had really good predictive scores, which means that, okay, well, we probably don't need to wait to observe 10 or 14 or 18 cases in a period of 72 hours. We probably can observe fewer cases, let's say 48 hours, 24 hours before sending out an alert. I think earlier alert messaging could be important. And the next step is some of the model tuning. I think we need to tune a little bit more the parameters for distance. The spatial aspect of it needs to be improved a little bit more in our model. And more importantly, what we want the model to be is automated. That is, basically once Trinity EMS does its ambulance run and the data is uploaded into their online service provider, which is First Watch, they flag the data based upon some of the text that is within the reports. What we are going to implement is that the text will go into our our system, which processes those texts, identifies an ORI case, puts it back into the model, and generates a probability of like, what the number of cases will be for the next 72 hours, given what we've observed in the past, and generate alert based on that. And then taking all of that and packaging it into the current alert system, which basically relies on just the number of counts over the 72 hours to generate alert. Next slide. So moving on to the second objective, which was evaluation of ORI communication channels. So what we thought initially was that, okay, well, if we can improve the ORI alert mechanism and get alerts out quickly, we could probably help people with drugs or other vulnerable population. But when we examined the literature on like how these messages are used or communicated, we didn't really see anything being done. So we added this objective to the study, which was to evaluate how ORI messages are communicated and what people do in response. So what we did was we conducted 2 sets of key informant interviews, one with opioid stakeholders and other with key informants, which included people who use drugs. So we have completed about 12 key informant interviews with opioid stakeholders and 15 key informant interviews with people who use drugs. And in our next step in December, we will do a baseline survey of about 100 people who use drugs to evaluate how they use that information. Next slide. So these are some preliminary findings from our study. First is that, this is from the stakeholders. There was some form of limited information about or lack of knowledge about a formal ORI system in many stakeholders, that they did not or have never heard of these formal systems in place. And also another theme that we discovered was that there were some hidden population, that is people living in residential areas or living alone, could possibly not get some of these ORI alerts that were put out. Next slide. And back to these stakeholders, KIIs, when we asked about, okay, what would be the best way to communicate this messaging? We were told that, okay, well, there's no way to wrong way to transmit or spread these messages. And there is, it is important that we use as many channels as possible. And there is importance of word of mouth, and also text and phone alerts could also be very useful to put these alerts out. Next slide. So now we can move to the key informant interviews that we conducted with people who use drugs. And we saw some kind of varying degrees of response in terms of like in what people do when they hear about increase in opioid overdose. There were a group of people who would say, okay, we would only buy from a trusted known dealer, make sure that they use with other folks, make sure that they have Narcan, and not use something that may have a bad batch or very strong. But there are also some group of people who indicated increase in drug-seeking behaviors, saying that, oh, if there's a batch that causes increase in overdose, they may go looking for it. People also indicated that there was some increased overdose risk to some certain people, especially in individuals with clean time, had higher risk of OD. There were some folks who were interviewed mentioning the same. Next slide. And in terms of where people were getting information about increasing overdoses or alerts, they indicated a group of trusted source of information. And one group which we found was very interesting was like police, and how they were, how the people who use drugs were talking to a cop, and how cops communicate that, well, there's increases in overdose and be careful, and advising people to be protected. And also other trusted source of information were local agencies and outreach workers who provided information through clinics or needle exchange programs. Next slide. And finally, in terms of communication methods, or like how people would want to get some of the alerts out, we heard that word of mouth, flyers, text and email alerts, or Facebook messengers, a lot of these different channels would be very helpful for the study participants to get these messages in time so that they could employ some of the harm reduction measures. Next slide. So what we learned over the here is that it is really important to have integration of community organization, public health departments who work with keywords for success of the study. And there was high success with the organization that was supportive of our research, but there were some challenges getting buy-in from some stakeholders. What is working is that the feedback that we're getting from key informants, both stakeholders and keywords, are very helpful in shaping how the alert system should work and how we should be sending out and framing the messages. And also that, with the collaborators, as we get to know more people and forge good connections, we are more able to include them in our study and get their feedback on alert design and system and how it might impact people who use drugs and other vulnerable population. Next slide. And some of the challenges that we encountered was that, while Lowell is a great city with very much supportive organization, there were some organizations whereby support was not as much as we'd hoped for, but that's, again, part of doing any study in this realm. And there was some challenges regarding use of EMS data itself and how to identify ORI cases. And additionally, challenges with recruitment and interviews with people who use drugs. And we also noticed a lot of opportunities. One of them was integration of drug testing that Alex and our team has been doing really well. And the study of non-opioid users and recreational users of other drugs who might be impacted by contamination and the current drug opioid epidemic. And the development of methods to identify ORI cases using an automated system with high precision, which I think we will be trying to implement that along with the ORI spike detection model. Next slide. And before I end, I would just like to highlight our study team members, Dr. Jen Putz, Dr. Sam Sapka, and our research assistants, Kevin and Grace, and our postdoc, Jack, and along with our study collaborators, Dr. Cece Bauer from UTH, John Kelly, Jamie Dillon from LCC, and Wilson Palacios from UMass Lowell. And thank you so much, everyone, for being here.
Thank you so much, Sikar. So we're gonna jump into the Q&A now. I just asked the panelists to put their cameras on so that we can start the Q&A. Let me just make sure that everyone is available here. And just make sure that the Reverend, I think the Reverend is coming back on in just a little bit.
Hey, we're trying to start the video. It said the host has stopped it.
Oh, the host has stopped it. I did not stop it. Very weird. See if that works. There you go. There you go. You're in. Okay. Excellent. All right. So again, thanks to everyone for just really fascinating presentations. I think you can see from the questions submitted, but especially the chat, that there is a lot of talk around the innovative ways that you're approaching the opioid crisis in your communities. So I want to we have about 10 minutes, and I want to make sure we have a question, start with a question for each of you. So let's start with ASAP. One of the questions that we have in here in the Q&A is around strategies that you have found that work best to engage faith leaders, that brings them into the training. We're not even talking about in the training itself, that actually gets them to the training. So how do you approach that? How do you gain buy-in? How do you support them and get them to a point that this is something that they should be focused on?
So actually, it's a very interesting question because we've had to work and tweak it over time, and we hadn't been doing it long. But I would say the most important thing is face-to-face communication. Myself and one of my colleagues, Jason Lindell, Sayram has sort of like dispatched us throughout the state, depending on which region we're working. And, we've sent letters, we send emails, we've done sponsored ads on social media, but nothing has worked as well as sitting face-to-face in a pastor's office. I think that's, as a pastor, I would say, I think that's because a lot of times we're doing so many things, right, that it's hard to focus on something or set aside time for something. But I would definitely say because that face-to-face engagement gets that time and their attention. And then when you talk to them face to face and share the information, they eat it up because they recognize it's something that's prevalent in our communities and also in our congregations and parishes.
I mean, I think that the face-to-face aspect, I think is so, I mean, we say that in business, that there's nothing that substitutes a face-to-face business. So it should be very similar, I would think, in getting people to engage in anything. Right. Fantastic. And just to follow up on that, you know, there's a lot of interest in the actual curriculum itself.
Yes.
Do you plan to make that more available, provide that information to SAMHSA? I guess, what are the plans to help expand this?
Yes, we do. We created the curriculum with the Alabama Department of Mental Health, or ADMH, but we do plan to eventually get the curriculum out as far as getting it vetted by SAMHSA as well, and hopefully getting their stamp of approval on it too. But once that's done, then we're going to just spread it out to as many people as possible. We don't want to, even as an agency, operate in silos, as Reverend Jackson mentioned earlier. So as soon as we get that, hopefully SAMHSA approval as well, we're going to send it out to everyone. But as of right now, it is approved by the Alabama Department of Mental Health, which has in turn made us be able to provide those certifications to the participants.
Great, that's fantastic. I'm sure there's a number of inquiries into getting your contacts information. So I have a feeling that you will be getting some emails about your program after the webinar. I want to move on to Marinda. You know, one of the things that, I've been privy to get to hear, as the projects move on is, some of the, what the concerns are amongst nurses around stigma, around opioid use particularly. Can you share a little bit about that? What surprised you about some of these, the points of contention around stigma and what nurses are worried about?
Sure. So what we found through our research was that nurses felt like they didn't get adequate training for how to communicate with patients that have opioid use disorder in a professional, empathetic manner. And also, what's the best treatment? How do you treat pain for somebody that also has opioid use disorder? And how do you minimize stigma associated with it when you are interacting with patients?
That's great. I think that, we often, see in the data that nurses are the most trusted healthcare provider, yet still there is a lot of pervasive stigma around these patients. So I think the work that you're doing is going to be instrumental in training those next generation. It
wasn't always bad feedback. Some patients or some participants had told us that there were nurses that did an outstanding job and were really helpful. So I don't want to portray it as all being negative stigma, because there were some people that were really beneficial. That's
great. Let's move on to Alex. We did see a question in the chat, and I know that you've been working on the xylazine communication quite a bit. And someone asked about xylazine and naloxone. And so just wondering if you can comment a little bit about where naloxone plays a role in all of this.
Yeah, so xylazine is not an opioid. It is a veterinary sedative. And so because it's not an opioid, Narcan will not counteract its effects. However, all of the samples we have tested that have xylazine in them also contained an opioid. So we really want to keep people using Narcan. We don't want any of our messaging to maybe have people go like, well, if it's got xylazine, then can't do anything. So we really are saying, if it looks like an overdose, still give Narcan. And, if folks still look pretty sedated, still pretty groggy, if you feel comfortable and it's safe to do so, do call for EMS help. Because we really don't want in our messaging of some of the new substances we're seeing to undermine existing harm reduction messaging. We want it to still do what you're doing. And here's some other tips. So.
Great. And we have a question that is asking about, specifically the toxicology studies on the samples. Can they, I think I know the answer to this, but, can they be done, in a more mobile way, a mobile unit to access street level use, as opposed to having, sit in a lab? Or what are those various options, I guess?
Yeah, so the testing we do on the LC-QTOF MS, that is definitely a lab-based machine. It's very large. The the person who operates it, they're trained, like highly trained technicians, they're trained as chemists. So it's a very kind of complex machine. However, there's some really amazing, more portable options that are often integrated in supervised consumption sites. I used to work in Canada and we had some there. And those are usually FTIR, which is an infrared mass spectrometer, or GCMS. And both of those are more portable. They are more integrated, easily integrated into community or mobile settings. So I think there are limitations to an FTIR. I'd say a GCMS would be the next kind of best option. But the one that we're using is kind of the max sensitivity, the most kind of comprehensive and confirmatory. That one is definitely a lab-based, but you can use like a mobile version and get it further confirmed, you know, at a hospital or state laboratory. So all options are great. It's just getting it out there to community, in community spaces, I think is a really fabulous option.
And every single one of those has its limitations, obviously. Yes. So, and I know that the way you thought about this was, you know, university labs, you know, universities all over the country have this machinery ready to go. So, you know, can we leverage those resources in those communities without having to reinvent the wheel and find financial resources to create it?
Yeah.
So, fantastic. And Seeker, you know, I have a question. You know, today actually, you know, ONDCP and the National Highway and Traffic Safety Administration, they released a new tracker that actually looks at EMS data as a way to look at real time. I think it's every 2 weeks they're updating it for non-fatal overdoses. And you mentioned, you know, that there's some challenges, you know, with EMS data. So can you speak to some of those challenges that you know, we still have to, you know, kind of get over in order to get to a more real-time accurate system?
Yeah, definitely. You know, and that's the challenge that we are also facing with our analysis is that, okay, how do you identify an ORI incident? You know, at first we thought, okay, yeah, this is going to be a bit complicated, but manageable. But then there's like levels to the issue. Firstly, is that, okay, well, if somebody has an overdose and naloxone has been administered, look, it's much more easier to identify the cases. But there are also many cases where people with opioid use disorders have called 911 for other things surrounding, you know, their health. But OUD or like in possession of like, you know, heroin or fentanyl or other paraphernalia are noted. Or there are also other cases where there is a mental health issue surrounding opioid use disorder, and that is noted. So it is very challenging to distinguish a lot of these cases among each other. And also, you have to know that while naloxone is used most all cases, not all cases have identified those naloxone administrations, especially when the EMS personnel did not do it. If somebody else does it, like it may not be recorded as easily in the reports. So there are some challenges in identification of these messaging, and we are trying to develop a method like using some form of NLPs, using the complaints, the nature, all of the text-based reports that are included in a report to identify ORI incidents with higher precision, which can feed into our model for spike detection. So that's something that we are trying to include, and we are also reviewing a lot of the protocols that different states have for identification of opioid-related incidents. And there's also a lot of variation in that. Massachusetts has really detailed instructions, but they also combine some other data sources that are not the EMS itself. So that's another challenge that, you know, because we don't have the, let's say, ED data associated with the EMS. So these are all issues that needs to be tackled, and we are always working with a limited limited knowledge constraint environment. So we have to work with what best we've got with the information and use that to create those models to the best of our knowledge.
And you know, that was, you know, the exact thinking of, you know, as we developed our innovation portfolio, especially amongst our data grantees, is how can we get people working on different aspects of looking at real-time data, bringing them together and developing a better system. So, you know, I think the challenges that you are overcoming are going to help, you know, in multiple aspects of tracking the crisis, you know, as we move down the line. With that, it is 4:30, so right on time. I know we have some more questions in the Q&A. we will publish, an FAQ, with those questions and have them answered and post them on our website. The recording as well as the slides will also be available on our website. But we'd just like, again, to thank all of our panelists today and just the incredible work that they're doing, as well as yourselves in the audience. Thank you for getting to the end of for staying with us to the end of the presentation. And we hope to see you on our next webinar. Hope everyone has a great day.